I thank the organizers for asking me to talk about the communication problem. I think we all know what is importance of this topic. Why communication is an important thing. The picture says everything. I need not talk about that actually. So the main difference between human being and animal being is the communication. So communication is the main function of your brain. And so what are the common case scenarios? So why should a pediatrician should know about communication? The communication, we always think only about the speech things. We ourselves have a lot of doubts, and parents will have their own doubts. If you and even if you say that there is a delay, nobody is going to accept you very easily. This every pediatrician come across, and many times we ourselves can get convinced, yes, the child will talk later. We need to know there is a lot of variations in the development of language up to 2 to 3 years of life. Certain children may be and even the language also going to play a major role actually. Our textbook says that even in the Italian children talk more during the early infancy compared to English speaking child. We don't have data to compare with Indian language, but there are, so the language also plays a role, environmental plays a role, intelligence plays a role, positive environment, and the stimulation in the family setup plays a role. Lot of things are placed. So the common case scenarios when we come across is the child, we may not be able to understand what the child is talking. The child may not be responding to our commands. There may be an unclear speech. They may not be able to combine the proper in a proper way with the words, may be saying very few words. They may not be interacting socially. They may be struggling to talk. A lot of things are there actually. So these are the common case scenarios. So we should know what is the basic of language actually. So first things I always say, differentiation between speech and language. Speech means just refers to the verbal production of language. Language means it's a conceptual processing of communication. So the prevalence, it says almost, it differs actually. Most of the studies are done only in South India. So it varies from 13 to 4.5, 5.5. That's long back. We did a small study in Harry Potter's textbook say there is equal. Male and female have a equal prone, they're equally prone for that. High risk to the preterm babies and low birth weight babies. So for this is called communication chain. So we all need to understand what are the process involved in a communication of a child. The child first has to look and attend. See, we need to say, I always say, even a hello, saying hello can be different. A hello to your boss is different. Hello to an employee to employer, employer to employee, or a hello to your friend, or a hello to your own child. This differs. So your body language also plays a major role. So a child has to look at the speaker's intention and their emotions, then interpret it. Through that they have to interpret the non-verbal communication. They have to listen. They have to have a good auditory memory, so they need to remember what they ask. They should be able to understand the words, that's called semantics. Then they should understand the sentence structure. Then they understand the meaning. Then they should form your ideas and decide and choose the words and decide the answer. They have to choose the words. They have to choose the sentence structure. Then they have to select the sounds. Then they got to coordinate the speech muscles, then articulate sounds, speak fluently, then speak appropriately. So communication is not a very simple process. Of course, it happens just like that, but it needs a lot of things into this actually. So for that, to make it a very simplified, I should have a normal hearing. I should have a normal listening capacity. I should have the coding and decoding and integration processing thing. That is a motor. Then should I have good motor response. Then I should have a vocalization and articulation. And it involves the function of ear. It involves the attention span. It involves the auditory cortex, vernix area, arcuate fasciculus, Broca's area, larynx, and neuromuscular things. So the bulbar muscle involved. So lot of processes are involved in the communication. So if the child is having problem in any of the things, though the child is going to have a communication delay. So I'm not going to talk only about speech delay. I'm not going to talk about autism. I'm going to talk about all the whole actually communication problem. So before going to that, we should be aware what is the normal language. Should know that there are 4 phases of the language milestone: prelingual, early lingual, differentiation phase, and completion phase. So the prelingual is 0 to up to 1 year. Then early lingual is 1 to 2.5 years, and differentiation phase 2.5 to 2.5 years to 5 years, and completion phase is 5 to 8 years. So I need not go to in the depth of these things. Just we need to know there are 4 phases of development. So by the end of 8 years, the child has to know the grammatical. The child has to talk without any grammatical error. So from vocalizing, then babbling, then gradually they have a proper articulation without any grammatical error. So 0 to 8 years is the milestones. We need to concentrate on that. And that too, the early phase, first 2 years to 3 years, were very, very important. So the classification, really it's a confusing. If you go to if you ask a behavioral therapist, if you ask a psychologist, we pediatricians have nothing to do with this actually. So we may get confused with the classification of speech and language disorders. So for simplification, I put it like a primary and secondary. There is developmental language disorder, receptive language, express. These comes under primary. So secondary is autism, dysarthria, hearing loss, intellectual disability.
Sudha, you have muted.
Is there any problem in my?
Yeah, you have to share the screen.
Yeah. Sorry. Now only notice that, sir. Sir, which slide actually?
No, the primary
is not available.
Primary, secondary, that differentiation.
Yeah. Okay.
From that side,
thank you so much. Yeah. So it's only we made it the classification very simple.
No, now the screen. You have not shared the screen.
Primary or secondary.
No,
the primary is going to be the level. There is a disconnection. Okay, 1 minute, please. I will share it. I think my internet connection is unstable. That's what's showing actually.
No problem.
Is it visible now?
Yeah. You start from this slide, sir.
Okay. So the classifying, there are a lot of different classification available. For simplification, we can have a primary and secondary. The primary is the developmental language disorder, receptive language, expressive language. Secondary may be due to the autism, cerebral palsy, childhood apraxia, dysarthria, hearing loss, intellectual disability, and selective mutism. So DSM-5 criteria this is what Nelson recommends. DSM-5 criteria to make it very simple. It is a language disorder, speech sound disorder, social communication disorder. So it is very practical for a pediatrician to follow DSM-5 criteria than the primary and secondary. So this is the thing. Phonological disorder we often come across in the things. So articulation problem, the words may be substituted, the letters may be substituted, that may be distortion in them, that may be addition of extra words. So there's an example of an articulation disorder we commonly come across the children actually. Next, the voice disorder. This usually we may not come across. It is not a very common thing come to us actually. There may be difference in the pitch, frequency, quality, the nasal twang of there may be increase in the hypernasality, there may be hyponasality. These are things usually we don't come across in our private practice actually. And the fluency disorders, this is very much important. We had because many times we parents will approach us only. So that's a fluency disorders refers the interruption of the flow of speaking characterized atypical rate, rhythm, and repetition in sounds, syllables, words, and phrases. The best example is stuttering. There may be hesitation in stuttering. There are a lot of things that are actually. The stuttering is the one of the best example because 5% of children will come across this stuttering during their development before they reach the 5th birthday. And it is considered the one of the most common, very correctable fluency speech problem in the childhood age group. Usually they develop between the age of 2.5 to 4 years actually. So So we need to know when to refer, because parents will be fully dependent on pediatrician. They will expect us to say whether the stuttering is normal or not normal, whether I have to go and approach for a therapy or not. So here we cannot just like that send to a speech therapy, because many times they also not available or aware of this all these things. They may simply start therapy, which may not be needed actually. So in that, for that sake, I'm going to say that there are two things, are the typical stuttering and non-typical things. So typical therapy, whereas the non-typical children, they have to be referred for therapy. So repeating phrases, he took it, he, that kind of things. And the whole words can be repeated. The phrases may be repeated or words may be, but that's what I have given an example. There may be use of filler words when that kind of things, or there may be no tension or physical. The child will be playing very casually, talking to you, but they'll have they'll stutter actually. And there is no secondary problematic behavior when they are speaking actually. Then there is no negative reaction or frustration, and there is no family history of stuttering, and the deficiency is less than 6 months. This is the things where you can very well reassure the parent. Yes, you can very well wait. The child will outgrow it, and the child will be talking normally by the age of 5 years. And non-typical is the repeating the sounds or sound prolongations, or and physically they struggle when they are talking. They have a secondary behavior. So they may be having, like, it may look like a tic disorder for us actually, but it is not a tick. The child is developing a secondary behavior. Then a negative reaction or frustration to speak. Negative reaction means they're losing of self-confidence. They may get frustrated. They may show the temper tantrum, lot of other things. And there is a family history of stuttering. There are many times we can come across family history of stuttering, especially in the fathers actually, or duration more than 6 months. And another things we need to know, if the child is developed stuttering after the age of 4 years, yes, we need not wait for another 6 months. Please start the therapy. So when to refer for stuttering, there is a family history, stuttering for more than 6 months. There is a negative reaction to the parent concern. If the parent is going to have a concern, definitely it is going to influence the child in a negative way. There won't be a proper stimulation. The child may end up in secondary behaviors later. So this is very important. Another thing, the child may not have stuttering alone. They may have some other associated developmental problems. So coming to the next things, this topic I need to very much want to stress on this developmental dysphasia. What is this developmental dysphasia? Significant discrepancy between the overall cognitive level and functional language level. I will just give an example. So the thing is, am I audible? Okay, this here, the significant difference overall between the cognitive, usually have difficulty in understanding the spoken language, but they may be good in repeating the memory. It's like echolalia. They engaged in pretend play, so imagination, are the emotional. There will be emotional reciprocity will be there, a joint attention behavior will be there. But there's some very few, like 10 to 15% may present within hypotonia, increased joint mobility, and motor clumsiness. And even they become fluent talkers later, they may be less proficient oral native compared to the other age, same peer group actually. And there may be a difficulty in social interaction, especially with the same age, but these children will be dependent on the adults or older children. So here, what is the importance of development dysphasia? These are the things we often miss or misinterpret as an autism spectrum disorder. I have seen many children labeled as autism spectrum disorder and started on therapies, various kind of therapies, a proper stimulation. So how to go with that? There should be a discrepancy between the overall. So the child intelligence level seems to be very normal. Only the language is delayed. There may be delayed in talking. Whereas in autism, the child will be talking normally up to the age of 1 to 1.5 years. Then the regression starts, and the regression fully develop by the age of 2 years. And usually have a difficulty understanding the spoken language. Here the child will respond but may not be able to understand properly. Whereas autism children, even they are not going to even attempt to understand what we are talking. The echolalia is going to be the same, which is going to confuse us between the autism spectrum disorder and developmental dysphasia. And here the engagement in the pretend play, which is completely absent in, especially emotional respiratory, absent in the autism spectrum disorder, whereas it is normal in the developmental dysphasia. This muscle tone hypotonia can be seen in both in autism spectrum disorder as well as developmental dysphasia. So the difficulty in social interaction, this is another thing confusing between the ASD and developmental dysphasia. The social interaction in ASD is absent through whether it is with an adults or older children or same age group, it is completely absent, or it may be the child may choose only 1 or 2 children among them. So whom they will be following the child. So they want to have someone to fulfill their needs. Whereas in development dysphasia, because of the communication problem, the child is not able to communicate to the same age peer group. So they understand that adults or older children are able to understand his needs. So he is dependent. He will be able to socially interact with the adults and other older children. Next comes the isolated expressive language learner. These are called late talkers. This one is very common. This is the given. Many times parents will tell you, if you say there is speech delay, அம்மா அப்பா என்ன சொன்னா, அவங்க அப்பா இப்படிதான் பேசினா, அவங்க அம்மா இப்படிதான் பேசினாங்க, எங்க வீட்டுல எங்க அம்மா சொன்னாங்க, எங்க அப்பா சொன்னாரு, இதெல்லாம் சரியாயிரும். So in this condition, there is delays occurring in the maturation of the central level, but it is more common among the boys. There is a family history of late bloomers, but the prognosis is excellent. They usually have a normal speech by the age of school entry. How to differentiate? The thing is, the child will be completely normal in all the other aspects except the expressing his needs and everything. So the normal, later on, they'll have a normal comprehension, intelligence, hearing, emotional, retrospective diagnosis in our setup actually. So instead of leaving the judgment to the parents, we should be able to judge whether the child is good in all the other domains. So we have to decide whether it is an isolated expressive language disorder where no need for any therapy, only the parental interaction with the child, decrease the media time. These are, and family involvement of the family members, keep on talking the child and stimulating the child to talk is more than enough for that actually. Then comes your expressive speech delay. So this case is expressive language disorder is another common thing. Here the speech is delayed, but the child have a normal comprehension, intelligent hearing, emotional articulation. Is difficult to distinguish from the distinct at an early age from the more common development speech and language delay. So the isolated late talker syndrome and expressive language also mimic equal actually, but a little bit different. But in both conditions, we need just a stimulation. We need not go for an, whereas in isolated late talker syndrome, we need not give therapy. In expressive language disorder, just wait for some more than 6 months. If it is still, it is there, please start the speech therapy. Receptive language disorder, receptive language never associate with present as a single entity. It is always mixed receptive. When we are not able to receive properly, I cannot express anything. So here there will be a speech is delayed, sparse, agrammatic, and indistinct in articulation. It's mainly in all the we have seen the communication network actually. So whenever there is receiving problem is there, the child cannot talk. So it needs intelligence, it needs a proper articulation, it may be a proper attention. A lot of things are needed actually. So these two conditions I want to talk, but I have not come across in my private practice, in my developmental clinic: selective mutism and childhood apraxia of speech. The selective mutism is an expression of anxiety disorder There have a strong familial trait. It may be both parent or either one of the parent will have a selective mutism. It is not a language disorder, but it is a reflection of difficulty in social interaction. So the therapy is focused on the anxiety, not on the language problem. How the present is selective, the child will be very talkative in the home. They'll be able to communicate in the home. They'll be able to communicate in the parents and grandparents, everything. But when it comes to school, they never open the sun. They maybe look like a very adamant, arrogant child, actually, or it may be like an unintelligent child. They many times even we have come across. I have come across when I started to talk in the forums. I have a selective mutism. When I come to in front of mic, I have a mutism for that, actually. So we need to overcome that. So it is an anxiety disorder. It is not a language disorder. Next come the childhood apraxia of speech. To be very honest, I have not come across such a case. Okay, so it's a textbook says there is a difficulty in planning and coordinating the movements of speech production. Some word may be pronounced very differently each time. Yeah, same umbrella may be pronounced different time in a different way. So there may be history of delayed onset of spoken words, a limited sound production. So there may be limited oromotor or associated with gross motor. So these are the very simple thing we need to know. Receptive and expressive. So 0 to 2 months, receptive language, the child turns to sounds, prefer voices, interested in face. Whereas an expressive cry. So which comes first? Expressive speech comes first. The child immediately after we start our communication immediately after birth. So we express by crying. So 2 to 4 months the extreme, whereas express is babbling. 9 months receptive understands verbal routines, express is pointing towards that, actually. 12 months follows a verbal command. In expressive, jargon word or jargon speech are first words. 15 months they point to the body parts when we name it, actually. Expressive learning new words slowly by 10 to 20 words, but usually we have a limitation of, we say at least 3 words. Receptive 18 to 24 months, receptive, they have to understand the sentences. Expressive, learning new words quickly. From 50 to 100 words, a child can talk even up to 200 words by the end of the 2 years. They are able to talk, uses 2 word phrases. By 2 to 3 years, they'll be able to answer all the questions. They'll be able to follow 2-step commands and express a grammatically complete sentence and ask what questions, and many times these questions are 50% intelligible. 33 to 4 years, they're understanding much of what's said and ask why questions, and 75% of their talk is intelligible. And 4 years to 5 years, understand much of what is said and commiserate with cognitive level, and they creates well forms and tell stories. And actually we can know that by 3.5 years the children are able to tell stories, but it's very short stories, but most of the repetition. Whereas in the end of 5 years they will start tell their own stories. What is happening in the school, they'll create stories and tell that, actually. So coming to as a pediatrician, what I need to know, we point the red flag signs. So when I have to intervene, when I have to, so this is one example I'll just put. This is response to sound, actually. So birth to any age, the child has to respond. So if there is no response to sound or lack of interest in interaction with the parent, so there is some problem in the communication. So from birth onwards, we can find out a communication delay. So at the first vaccination or in the newborn follow-up or any newborn checkup, please check whether the child is having a response to sound. It may be due to hearing, it may be due to some neurodevelopmental disorder, or it may be due to the communication problem. So by 4 months, when the child comes for 3.5 to 4 months for the third vaccination, the lack of any, the child is trying to communicate you, whether the child is smiling. Before putting injection, just play with the child, check whether child is smiling at you, whether they are, by simply playing with an, by changing our facial emotion, we can make it out there a problem in the communication. By 6 to 9 months, while you're going for flu to MMR, look for absent cooing or popping, absent cooing or babbling, or localization or lack of responsiveness. This is going to be a very important thing. See, the absent, we need not wait for the child to have parents to come back to you to say by the age of 3 years, because why am I mentioning the 3 years? This is my clinical scenario. In my clinical scenario things, I have come across 90% of the time parents come to you by the age of 3 to 3.5 complaining that my child still not. Why the 3 to 3.5 years? That is a period where the child has to go for school. They'll be denied admission. So it is not the parental concern. It is the admission concern. So we can make it out from these 6 to 9 months. By 12 months, failure to use mama or dada, loss of previous language or social minds indicating the autism spectrum disorder. So by 15 to 18 months, when they come for MMR varicella, look for no single words, poor understanding of simple commands. It's like single commands actually. Simple commands mean single commands. In the phone, the glass, this kind of single words, single commands, if the child is able to understand. So the for 18 months, the child used to start walking. By the time they'll be exploring the environment, they'll be very happily exploring the environment. Come for a typhoid vaccination, check how many words the child is talking. Less than 50. Here the words should be meaningful words. Very many times the parents are nalla pesra. It may be an echolalia. It may be some meaningless words. So it is be a 50 meaningful words, and that should be, if there is no 2-word phrases, ideally many times the children will be able to talk 3-word sentences actually, but minimum they should have a 2-word phrases, and less than, if there is a less than 50% of the speech is intelligible to the stranger, you please try to talk to the child, actually communicate to the child. By 3 years, if the child's come for will be any, by the 3 years the child will have some URI, they'll go to start going to school, they'll have some kind of problem. Look for whether the child is having 3-word phrases. If there is no 3-word phrases or no 3-word sentences, and it should be 75% of the speech has to be understandable. If it is not understandable for us, yes, the child is having problem. Here comes the problem with that. Rote memory, we call it rote memory. The child will be able to repeat the rhymes, whatever this in the pre-KG. The child may be able to repeat the numbers, rhymes, they might, but everything may be a simple imitation. It may be an echolalia or it may be a rote memory, where the child may be producing everything on its own, but not on demand. By 5 to 7 years, if the child is having immature or inaccurate speech, yes, it is very, very important. We need to refer the child. So early detection plays the major role as a pediatrician. So the screening for the speech delay, we have to have our own screening tool of list language evaluation skill Trivandrum. We need to thank Dr. MKC Nair for giving such a simple tool actually. These are the two tools, list 0 to 3 years and 3 to 6 years. It's a such a very sensitive tool. If there is a 1 item delay is there, it have 81%. If there is 2 item delay is there, that is sensitivity is less, but the specificity is going to be very high actually. So ideally, as a pediatrician, if there is even 1 item delay, is please refer the child to a developmental pediatrician or neurologist. And another request is never refer a child to speech therapist directly without referring to a neurologist or developmental pediatrician. Many times I have come across in my practice, a child undergone therapy, speech therapy for complete 2 years without talking any talk, because later only the child has identified doubt that speech therapist had a doubt that the child is maybe have an autism. It's a non-verbal child actually. She was trying for 2 years, putting the blame on the mother, that mother is not giving the proper stimulation even though she is telling. The child was repeating few words as an echolalia. They are using the echolalia or voice imitation or word imitation as an improvement in the therapy. It is not the actual. The child would have done even without speech therapy. So before referring, first as a pediatrician, we have to clear, yes, this is the communication delay, this is the type of communication delay, this child needs this kind of therapy, because parents are fully dependent on us actually. So please always use MChat. I repeatedly tell you everywhere, please use MChat from 16 months onwards. It's very, very easy. Only thing is you need to have an repeated interpretation, because even you yourself can misinterpret a lot of things, and mothers may give lot of wrong answers. See, this once you start practicing, will come across actually. நிறைய டைம் நீங்க கேட்டீங்கன்னா, நான் குழந்தை பேசுதான்னு கேட்டா அம்மா மதர் ஆன்சர் will be yes. என்ன பேசுது? அம்மா அப்பா சொல்றோம். That is not a meaningful words to say. So if you say ball, the ball may be differing in the shape, size, everything, but whatever the change is that the ball is a ball. So the child has to understand and tell that actually. அதே மாதிரி eye contact, whether there is an eye contact, the mother says, நல்லா பாக்குறான் சார், என்னை பாப்பான் சார். When he is looking at you, when there is a need, the child may look at you. நீங்க பால் வேணும்னு சொல்லி பால் கொடுக்கும்போது the child will comment. When he is getting that, he will be looking at you. அதுவும் அம்மா நின்னுட்டு குழந்தைக்கு கீழே குனிஞ்சு கொடுத்தா child will look only at the milk, not at the mother's eyes. If the mother is sitting and giving, the child will look at the milk along with the mother's eyes. These are small practical things which I learned once I started practicing. So many times parents misguide us by MChat filling. So we have to understand the proper way of MChat. Then we have to start using the MChat, because no one else can use MChat other than a pediatrician. And we have a very good opportunity to use the MChat during the 1.5 years vaccination. Please never miss it. I have unfortunately come across few case scenarios where in abroad countries, US also, they are not used MChat, and the children end up in autism by find out by someone else by the age of 2 to 3 years, and they travel to India for therapy. So while history taking, whenever your child come across communication delay, please go with detailed history of language development milestones. For that, we should delay. So we can use either Denver or whatever the thing, TDC, whatever thing you are comfortable with. The trigger question to be asked to the parents, it's from my own practice. How does he communicate his needs? The child may be communicative. The child may get whatever he wants. அவனுக்கு பால் வேணும், பால் வேணும், பிஸ்கட் வேணும், எல்லாத்துக்கும் he may, how he communicate. Narrate time parents may not be aware of that. He'll be coming and asking, pulling your saree and taking you to the table and ask everything. That's not a right communication. He has to communicate with words. Does he respond to the sound, or he over responds to the sound? What all do you think when what she understands? Whether the child is able to understand your simple commands? Will he or she point to the decide object, nod and shake? When say no, வேண்டான்னு சொன்னா, the child has to say no decides actually. Whether the family members are able to understand his speech, whether his own ability to understand the feeling of others. Amma aludukittu irundha, whether the child is reacting. When the whole family is having some grievance, they are very sad. The child should not be keep on playing with everyone, or need not bother. But sometimes will be keep on moving. The child is having. Many times children with communication disorder have a solitary play. That's especially the autism spectrum disorder. நல்லா விளையாடுறாமா, will be keeping it general question. நல்லா விளையாடுறான் சார். What kind of play? Different thing. Autismனா ஒரு காரை வச்சு தள்ளிக்கிட்டே இருப்பான், காரை வீலை வச்சு திருப்பி வச்சு பண்ணிக்கிட்டே இருப்பான். That's not going to be a typical thing. The child can have any type of typical play. So, but the thing is, it will be able to enjoy himself alone for hours also. So that kind of thing. So the child is ideally expected to get bored of single play. They have to look for going out actually. Is he interested in playing and interacting with the other children or family members? These are the trigger questions we need to ask the parents and get the answers from them actually. So medical history, you have to look for the cognition. So whenever there is a cognitive defect, you can't expect the child to have a speech, proper communication. When there is a hearing, that's what Dr. Abraham sir talked, elaborate. And then there is any motor, associated motor. This obviously we won't miss these things, medical history. And always ask for family history of speech delay, other domain delay like motor, gross motor, fine motor, social, whether the child is having learning disability, which nowadays you need not wait for 7 years to label a child, but you can doubt from the age of pre-KG itself. We'll look for any family history of hearing impairment, we have family history of any genetic disorder. So examination, always observe the child, how they interact with the parents or children. Either if you are not able to observe, please tell the parents to observe it, take a video of that. Many times I ask the parents to take a video of the child while they are playing with the other peer group or siblings or in the park. So it is going to give a lot of answer for us actually. Look for dysmorphic features, look for neurocutaneous markers. Inspect, have the habit of checking your external auditory canal actually, and examine the mouth and pharynx that many soft palate problems would have been missed actually, especially in the posterior 1/3, and look for CNS examination. So they look for other genetic like Down syndrome, history of seizures, cerebral palsy, all of the metabolic things often we don't come across in our private clinical practice. And socioeconomic status also, the lack of adequate stimulation, low parental education, then parental disputes also going to be have a problem with that actually. So diagnostic, I'm going to stop with that actually. So what is the effect of early identification and early intervention in communication? If there is an improved communication, the literacy is going to improve, which is going to improve the social skill, which is going to develop the peer relationship, which is going to develop a self-confidence and a proper behavior. It is a complete man or female woman will be coming out of that actually. So this is a small myth only. There are a lot of myths about that actually. So we can come across speaking more than one language, delay speech, nothing. By the age of 3 years, a child can learn up to 6 languages. We can see many Nepali children working in our flats as a watchman will be talking to Nepali with parents, talking to us in Tamil, and they can go to school and learn language English also. So it's very simple thing. They can learn any number of language. Children always outgrow language delays and catch up to their pace. This is the most common statement we come across. Often, unfortunately, we also make this kind of statement. This is applicable only to the late occur syndromes. Boys always talk later, so parents should not be worried. It is not actually. Late occur syndrome is very common with the male children, so that has been misinterpreted actually. The child cannot be tested for language until they are in the school. Nothing, I have already mentioned, they can be tested from since birth itself. Speaking in baby talk to your infant cause language disorder, no, that is like that. If the child is having a normal cognition, they can differentiate it. But still, we always advise talk to the parent. You can, problem, but still talk to the child in a proper language. So take home message is, speech and language are different. We should know the cardinal milestones of speech development in order to pick up delays at the earliest. It could be isolated speech delay or a part of GDD. We have to differentiate. And all children must undergo hearing evaluation, as Sir says, Dr. Abraham Paul said, and we have to screen the children for using LEST, TDC, and MChat. So whom we have to refer? We have a lot of private centers. Of course, I am in a government servant. I have put 2 places where I learned the whole development. First picture is the ICH. It's an illuminated ICH and taken the night time. So you can see the picture. It's like look like a corporate hospital. Second, on the lower is where I am working at present, Chengalpattu Medical College. Such a very nice things. We are having 2 speech therapists in Chengalpattu Medical College. We have 2 OE machine, Ubara machine. So it is not costly always, as we think. We can use the government, every government hospital, including headquarters hospital, or nowadays supplied with the OE machine. So please refer the children to the therapy for any medical college hospital. 100% sure they will get the proper therapy process. Only that is going to help the mother. So a humble request as a developmental pediatrician, please don't wait and watch, just begin to act. Thank you. Thank you for the opportunity.
Thank you, Dr. Sudhakar, for this extensive presentation and bringing out the differences between the basic sound speech disorders